Third branchial cleft anomalies are rare, representing 2% to 8% of branchial cleft anomalies. Distinguishing between third and fourth branchial cleft anomalies can be clinically challenging. Therefore, these anomalies are sometimes grouped together as pyriform sinus fistulas. The anatomical course of these anomalies can be quite complex. The cutaneous opening are typically located at the anterior border of the sternocleidomastoid muscle at the junction of its middle and inferior thirds. The tract travels superficially through the strap and platysmal muscles, then continues inferiorly along the internal jugular vein and travels deep to the sternocleidomastoid along its anterior border. It then turns laterally to pass deep between the glossopharyngeal and hypoglossal nerves before looping inferiorly and passing superficial to the hypoglossal nerve. The tract continues posterior to the internal or common carotid artery before coursing superficial to the vagus and superior laryngeal nerves. Finally, it pierces through the thyrohyoid membrane and opens into the base of the pyriform sinus. Preoperatively, it is difficult to differentiate between the third and fourth branchial cleft anomalies. Commonly, the fourth branchial cleft anomalies arise from the apex of the pyriform sinus rather than the base, which may be determined at the time of diagnostic rigid endoscopy. The fourth branchial anomalies also arise posterior to the superior laryngeal nerve, whereas the third branchial anomalies pass superior to this nerve. Lastly, the fourth branchial cleft anomalies exit the larynx near the cricothyroid joint, whereas third branchial anomalies pierce the thyrohyoid membrane. The most common presentation of a third branchial cleft anomaly is recurrent neck abscess at the anterior border of the lower sternocleidomastoid, more commonly on the left. And acute suppurative thyroiditis may be seen in a third of cases. Radiological imaging can aid with the diagnosis and also preoperative planning. Barium swallow can reveal the presence of a sinus or fistula tract extending from the pyriform sinus. X-ray fistulography can be done preoperatively or intraoperatively to reveal the presence of a sinus tract, but it does not show the relationships between the tract and surrounding structures. Ultrasound can be useful in cystic masses or presence of air within the sinus tract. Computed tomography and magnetic resonance imaging can provide information on the relationships of surrounding structures to the tract. In an acute infected branchial anomaly, adequate resolution of the infection should be the primary goal, with a secondary goal of avoiding open incision and drainage if possible. Antibiotics are the mainstay of medical therapy. However, surgery is indicated for infections that do not resolve or progress despite medical management. In these cases, a needle aspiration or open incision and drainage can be considered, but it is important to be aware that this can create scarring, which could complicate subsequent surgery, and there is also the risk of iatrogenic fistula formation. In the setting of active infection, open resection is not recommended given the increased risk and difficulty of performing a complete excision of the tract, although tissues are significantly inflamed. Definitive treatment for these anomalies is complete surgical resection, which can be categorized into the three approaches: endoscopic, open resection, or a combined endoscopic and open approach. Thank you for listening and see you next time.